Hi there, good afternoon. Thank you so much for joining us today for our webinar. My name is Dr. Jennifer Lenahan. I'm a urologic oncologist at Providence St. John's John Wayne Cancer Institute in Santa Monica, California. And today you're here for prostate cancer, listen and learn. So we're going to spend your lunch hour hearing some talks from some of our physicians here, and hopefully this will give you updated and new information regarding both screening, imaging, and treatment of prostate cancer. So we know that about every 3 minutes, a man is diagnosed with prostate cancer. And for as fast as we're diagnosing prostate cancer, finally our treatment strategies are catching up. So just a few housekeeping issues before we begin. Now we're going to have 4 talks today, and if you have any questions, please drop your question into the chat box. Now, if you have any specific questions that you want to address or private questions, you can contact us at urologic oncology at the johnwaycancerinstitute.org or hit us up on our website at stjohnscancer.org urology. So today's presenters, we have the world-renowned Dr. Timothy Wilson. He is a robotic surgeon specializing in prostate cancer, and he is going to give you a great update on prostate cancer screening. We have Dr. Shemek Twardowski that joined us most recently from City of Hope. He is a medical oncologist who specializes in prostate cancer, and he's going to talk about the new imaging strategies, especially for metastatic prostate cancer patients. I'm going to give you a talk on some new enhancing options for radiation therapy, as well as a new focal therapy treatment called HIFU. And Dr. Mehran Movasagi, who's the director of our men's health program, is going to talk to you about testosterone replacement after prostate cancer, which is actually quite controversial. So before we begin, again, please drop your questions into the chat box and hit send. This is our website and phone number if you want to get in touch with us. And here we're going to start my talk about enhancing your quality of life for radiation treatment, as well as a new FDA-approved treatment called HIFU, which is high-intensity focused ultrasound. So we know about 1 in 9 men will be diagnosed with prostate cancer in their lifetime. And how we diagnose prostate cancer, screen for prostate cancer, and treat prostate cancer is incredibly important. So once we suspect a man has prostate cancer, we'll do a prostate biopsy. And here you can see there's 2 approaches. There's a transperitoneal and transrectal, and both are done with an ultrasound probe into the rectum. Now the transperitoneal approach is often advantageous because it has a less risk of infection. But all the prostate biopsies we do here at the John Wayne are done with both ultrasound and MRI guidance, and we actually fuse the images from the ultrasound and the MRI to take biopsies of the prostate itself. Now, to determine what type of prostate you have or the severity of the prostate cancer, this is really the stage and the grade of the prostate cancer. So the grade is the Gleason score, or what the pathologist sees under the microscope, and then he gives that a grading and tells us how aggressive he thinks the cells look under the microscope. And we also use other things like your PSA velocity and other genomic and molecular tests to understand whether the prostate cancer is low grade, intermediate, or high grade. Now, once we've determined that, we'll put the patient, through sort of an algorithm to figure out what treatment options are best. Now, most patients with intermediate or high-grade prostate cancer are really going to be candidates for either radiation therapy or surgery. In rare cases, patients who have low-grade prostate cancer are candidates for active surveillance, where we know you have prostate cancer, but we're going to monitor you by checking your PSA and sometimes rechecking biopsies, but not actively treat your prostate cancer. Now, for patients that do have intermediate or high-risk prostate cancer, they may undergo radiation therapy. Now, there are several different types of ways you can do radiation. You can do what we call 3D conformational, we can do intense modulated, we can do image-guided, stereotactic, and proton beam. Or you can actually implant radioactive seeds within the prostate. Some are permanent, some are not permanent implants, but either of these strategies can be used to treat the prostate cancer with radiation. Now, this does present a possible toxicity to the surrounding structures. We call those the organs at risk. So here you can see there's this radiation field going around the prostate that's intersecting with the rectum. And this yellow line is pointing at where the rectum is. And you can see the color strategy of where the radiation is going to reach. And you can see if you want to effectively treat the prostate, which sits right on the rectum, you're going to get some radiation that's going to reach the rectum. Now, how do we prevent that toxicity? So we have a hydrogel that we can actually put in between the rectum and the prostate to prevent the rectum from getting injury from the radiation. And that's why it's called SpaceOAR, because the rectum is essentially an organ at risk of unintended radiation. So, and if the rectum does receive radiation, patients can have lifelong problems with pain, bleeding, fistulas, urgency and frequency, to have bowel movements. So there can be issues if the rectum is impacted by the radiation. So again, how we help prevent that is it's a simple procedure that we can do in the clinic, and we put a hydrogel-based spacer between the rectum and the prostate to protect the rectum during the radiation. The benefits are that when the rectal wall is moved away from the prostate, it moves out of the field of radiation. And the hydrogel really only lasts about 6 months. So that's plenty of time for the patient to get the radiation treatment, and then the hydrogel absorbs after that. And you can actually see that on an MRI. When I insert the hydrogel, we get the MRI after, you can see it, and then after 6 months, the hydrogel gets absorbed and causes very few of any risk to the patient. So by using the spacer hydrogel to prop the prostate away from the rectum, you provide more space, which is fewer rectal complications, fewer urinary complications, fewer sexual complications, and ultimately better quality of life. So again, this treatment is called SpaceOAR. It's a hydrogel that goes in between the prostate and the rectum to protect the rectum during radiation treatments for patients who are getting treatment for usually intermediate to high risk prostate cancer. So if you want any more information, visit SpaceOAR.com on the spacer hydrogel. And if you're undergoing radiation, feel free to contact us and see if this product is a good fit for you and it's available for you to do prior to your radiation. Next, we're going to talk about a different treatment strategy for prostate cancer, which is focal therapy. So focal therapy is where we don't treat the entire prostate like we do in radiation or surgery, but we just focus on where the prostate cancer lesion is. So I wanted to go through sort of the evolution of prostate cancer management. Now, in the 1990s, we would diagnose patients with prostate cancer. And at that time, we didn't understand that some prostate cancers are very indolent and don't act very aggressively. So patients with both low risk, intermediate, and high risk prostate cancer were all treated the same and all sometimes got radical surgery or radical radiotherapy, and we only had one sort of treatment strategy. But as time went on, we figured that many of these patients are living well over 20 years after their prostate cancer, and that really preserving their quality of life should be one of the most important issues, especially when you have patients with low-risk disease, because those are the patients that are really not at risk for progression and metastasis, or even death from prostate cancer. And a lot of these patients were essentially getting overtreated. So as we started to realize that, we started to try to focus on therapies that were more minimally invasive, or push patients towards active surveillance, where again is we know they have prostate cancer, we're just not actively treating it. So we get about 30 million PSA tests every year, 1 million biopsies, about 200,000 new cases are diagnosed. Yet we still have 30,000 deaths every year, which is again is second to lung cancer. And we know there's about 3 million men out there living with prostate cancer at any given time. And you can see in this pie graph that over 35% of patients used to be overtreated for prostate cancer with more radical therapies. And again, as we realized that low-risk prostate cancer was very indolent, and even some forms of intermediate prostate cancer was indolent, we started focusing on treatments that had very minimal side effects. So the Gleason score, or the G score, is how aggressive the cells look to the pathologist under the microscope. So here you can see patients that have a Gleason 6 in green are really candidates for active surveillance. Yet as the Gleason score gets higher, the treatment strategies get higher. Patients need whole gland treatment with either surgery or radiation, and some patients who have very high-grade disease or invasive disease may need radiation, surgery, radiation, and androgen ablation. So where do the patients with the focal therapy fit in? So these are patients are sort of in this middle ground between the very low risk and the intermediate risk, who are the really good candidates for focal therapy, who get the best cancer of the treatment with the most minimally invasive side effects. And again, who can have focal therapy? These are patients with very low and low risk prostate cancer, and some of them with favorable intermediate prostate cancer. And this chart shows how we define that, but we may use other strategy like molecular tests or genetic tests of the biopsy tissue to figure out which category patients fall into and whether they're candidates for focal therapy or active surveillance, which again is watching the cancer but not treating it. So how do we decide on focal therapy? So we know that about 75% of the patients with prostate cancer will have multifocal disease, meaning tumors on both sides of the prostate. We also know that some of these lesions are higher grade than other lesions. So you may have a patient with a Gleason 7 lesion on one side and a Gleason 6 on the other. Well, the Gleason 6 qualifies for active surveillance, but the Gleason 7 may not. So you may do focal therapy to try to treat this particular lesion, to treat the prostate cancer that you're actually worried about. Now, of the men that undergo MRI and biopsy, about only 25% of them have unifocal lesions, meaning lesions only on one side of the prostate. And those, again, are good candidates for focal therapy because you're just treating the specific lesion. Now, there's several ways to do this and several types of energy you can use to deliver to the prostate to treat it. You can use the high-intensity focused ultrasound, cryotherapy, photodynamic, laser interstitial therapy, electroporation, radiation, nanoparticles, and radiofrequency ablation. Now, some of these treatments are still investigational, and we're gathering more data on how these treatments perform long-term for patients. Because for patients, remember, you want to prevent cancer recurrence, so you don't want the cancer coming back, but you want the minimal side effects and the minimal downtime. And so these focal therapies and these energy delivery therapies provide that, but you want to balance that with getting good cancer control. So and what I mean by that is focal ablation strategies by making sure you have good treatment margins around the edges of the lesions. And we know from our experience and our research that really a circumferential margin that's even only 2 to 3 millimeters around the area where the prostate cancer is provides a good treatment rate of over 90 to 95%. So you can treat a very small area that's close to other important structures with a good rate of efficiency. So let's talk a little bit about the principles of HIFU and how HIFU works. So this is an ultrasound, basically a prenatal ultrasound versus a HIFU therapy ultrasound. And it is basically the same ultrasound images, except the machine focuses the intensity of the ultrasound beam into one place, and that ends up 1,000 times more powerful than the imaging you would get for a prenatal ultrasound. And when you focus that beam, it actually creates energy and heat into the area of the prostate that you want to ablate. So HIFU works by two principles. One, it heats the tissue, and that causes destruction. And then also it generates gas bubbles within the tissue that basically rupture and cause cavitation or necrosis within the tissue. So these two things are happening at the same time while you're treating the lesion. Now here you can see untreated tissue versus treated tissue. And pretty much what happens is in the beginning you get what we call coagulation necrosis, which is just death of the cells. Then you get inflammation because the body realizes something has happened. So it calls all the inflammatory cells in to figure out what's going on and what needs to be cleaned up. And then you have fibrosis, which is essentially scarring. So as it goes through the process, that's how it goes from basically the death of the cancer all the way down into a scar tissue. Now, how we actually use the focal therapy, this is an example of what the machine looks like. And you can see the probe is going to go up the patient's bottom here. And the doctor is sitting here looking at the ultrasound images and the MRI images. Now, the machine, the computer, will actually fuse the images of the ultrasound and the MRI so that we know exactly where the lesion is. And once the computer shows you where on the prostate the lesion is, then the doctor can mark out on the MRI exactly where they want to be treated. You can also tell the computer the rectum is here, the nerves are here, the blood vessels are here, and then the computer will automatically keep you out of those zones so you don't end up treating structures that you don't want to. So it's a very advanced system that allows the computer technology with the doctor's eye at the same time to make sure you're getting treatment in the right place. So first you localize the lesion, and then the machine actually uses the focused ultrasound beams to treat the lesion. And this is a little graph on the morbidity of all of the different procedures for prostate cancer. Now, what's interesting to me in this graph is that even patients that are on active surveillance, which essentially is not treatment, still have some rate of incontinence and some rate of erectile dysfunction with prostate cancer, about 3% incontinence and 21% erectile dysfunction. Now, if you look at the patients who got focal therapy with the HIFU, they had about 3% risk of incontinence and 22% risk of erectile dysfunction, which is really almost comparable to the patients that didn't get any treatment at all. If you look at patients who had whole gland HIFU, meaning instead of just treating the lesion, we treated the whole gland, those patients had about a 3% incontinence, but a 37% risk of impotence, and patients who had radiation had about 4% incontinence and a 66% erectile dysfunction incidence. So you can see that with the HIFU, the morbidity for the incontinence and the erectile dysfunction is very low and is almost the same as patients undergoing active surveillance. So for HIFU, the quality of life benefits for the patient are there's no scars, no incision, no radiation. The technology is precise because you're using the computer to help you find the lesion with real-time ultrasound and MRI. The procedure takes a couple of hours. You go home the same day. You do have to have a Foley catheter in for 7 days. It's less time away from work and really has a low risk of side effects such as incontinence or erectile dysfunction. So we get high efficacy and low morbidity using the Focal One treatment for HIFU. And the reason that the Focal One is so important is because this is the only machine that's a robotic-based machine that fuses the images, helps you find the lesion, and then basically moves the arm back and forth to treat the cancer, making sure it doesn't hurt any surrounding structures. So that's really the technology that's Focal One, and it's a brand new technology that we're using for high frequency ultrasound for treatment of prostate cancer. So if you have any other questions, I highly recommend you jump on this website, which is https://ultrasound.hifu/prostate. There's some great videos for patients and more explanation of some of the risks of HIFU and the complications and some of the benefits as well. But also, you're welcome to come see myself or Dr. Wilson or Dr. Movasagi, and we're happy to talk to you through some of the treatment strategies of HIFU and see if you're a candidate for HIFU in itself. Now again, here is our private email if you have any personal questions to send us, and check us out on our website. So we are now going to hear from Dr. Timothy Wilson, again, world-renowned robotic surgeon for prostate cancer. He's going to go over some prostate cancer strategies for us.
Hello, and welcome. I'm Dr. Tim Wilson. I'm professor and chair of urology and urologic oncology at the John Wayne Cancer Institute in Santa Monica, California. Today I'm going to be speaking to you about prostate cancer screening. But first, a few facts about prostate cancer. Number one, prostate cancer is extremely common. It's the most common cancer in men. And it's the second leading cause of cancer death in men. Interestingly, however, many prostate cancers don't actually need treatment and can be monitored. It's also important to note that when men have prostate cancer, there's a laundry list of treatments that I'll show you later in the presentation. And side effects of treatment can result really from any intervention. But the goal of treatment today is to tailor the treatment to the details of the cancer, what are things that are known as the stage, the grade, location of the cancer. Furthermore, we want to tailor the treatment to the individual, such as the size of the prostate or the overall health of the patient. And the primary goals are to maximize cure and to minimize side effects. What causes prostate cancer? Well, age is a major cause. For men over the age of 50, the disease continues to rise and build and become more common. Genetics. We know that having a first-degree brother or father with prostate cancer doubles or triples the risk of getting prostate cancer. Also, men that are positive for the BRCA gene have a significantly increased risk of getting prostate cancer. We also know that race is important. So, for instance, men of African American descent have a much higher risk of getting prostate cancer than men that are Caucasian or men that are of European descent. We also know that there are environmental causes, such as firemen that are exposed to smoke, Vietnam War vets exposed to Agent Orange, and some factory workers exposed to certain and different kinds of heavy metals. Furthermore, we've recently discovered that recurrent and chronic inflammation of the prostate, referred to as prostatitis, can cause or lead to an increased risk of getting prostate cancer from a process known as chronic oxidative stress. This year, in 2020, there will be nearly 200,000 men diagnosed with prostate cancer. And there will be over 30,000 deaths from prostate cancer. Yet, we've come a long way, primarily secondary to screening and finding it earlier, and the cure rates for prostate cancer have improved dramatically. Now, why has this happened? First, I'm going to direct your attention to this little blue arrow here, beginning in the late 1980s, early 1990s, when we began screening for prostate cancer using a molecule called PSA, or prostate-specific antigen. At that time, when we started screening, the men that died from prostate cancer within 5 years of diagnosis was as high as 25%. 1/4 of those men at that time were dying from prostate cancer within 5 years. But today, as it was within a decade of starting screening, less than 1% of men diagnosed with prostate cancer were dying of the disease within 5 years of the diagnosis. Other large studies have been conducted with screening, and this one is excellent and was recently published, comes from Europe, and is a randomized trial where 162,000 men were randomized to receive annual screening or not. And in that study, they determined that there was a 42% reduction in metastatic disease, lethal cancer, in men that were screened. And there was an approximate 50% reduction in the death rate. So what about screening for prostate cancer? Well, beginning in the early 1990s and up until just recently, screening for prostate cancer meant checking the PSA annually and performing a physical examination, a DRE, of the prostate. And if either one was abnormal, the PSA or the DRE, then the patient was referred to a urologist and a biopsy happened. This was done even though the PSA above 4, which was the accepted upper limit of normal at that time, it only gave about a 30% risk of having prostate cancer. So of all the men that had biopsies, 70% ultimately didn't really need the biopsy. And of these men that had cancer that were diagnosed, of this 30%, only half of those actually needed treatment because the cancer was non-aggressive and extremely slow growing. So we've made a lot of progress since that time. And in hindsight, we know now that we were performing too many unnecessary biopsies. And as a result, we were overdiagnosing non-aggressive cancers that didn't need treatment. And we were treating men that didn't need treatment. But now we've made much progress. And the current goal today, of course, is to find the cancer early and try to only find, or best find, cancers that are potentially lethal, cancers that will kill somebody. So we still perform the annual PSA and digital rectal examination, but we have some newer tests. This is why research is so important. So there are several tests that fall into this category, but the two I like most are a 4K test and a test called the Select MDX. Now the 4K test is an adjunct to PSA. It actually includes PSA, but 3 other molecules known as kallikreins along with PSA. And in several studies, but this one in particular, looking at over 1,000 men using the 4K test and just PSA, the 4K helped avoid nearly 60% of essentially unnecessary biopsies, while only missing less than 5% of high-grade cancers. And it's currently part of the NCCN guidelines. This is an example of a printout of a 4K score test that I receive in the office when I send this blood test on a gentleman that I'm trying to figure out if he needs a biopsy or not. In this particular gentleman, he had a family history of prostate cancer, so I knew his risk was elevated. He had a benign feeling prostate. In other words, his prostate was smooth, didn't have any nodules on it, and wasn't suspicious for prostate cancer. But his PSA was rising, and he had the family history. But the 4K test showed only a 2% chance of having a potentially lethal prostate cancer, and therefore we were able to avoid the biopsy. This test, called the Select MDX, is also worth considering in men that would have otherwise undergone a biopsy back in the old days. It's a urine test that's collected in a small sample of urine after the prostate is examined by the urologist. And you can see in this particular gentleman that underwent the Select MDX test, it showed that he had a 50% chance of finding prostate cancer on a prostate biopsy, but a nearly 25% chance that he had a potentially lethal cancer, and therefore he underwent a biopsy. Studies have shown that there's a 27% reduction in unnecessary prostate biopsies using the Select MDX urine test. In addition to 4K and Select MDX, it's now become relatively routine if either of those two tests show an abnormal or elevated risk to get a prostate MRI. Now, prostate MRIs have been used for quite some time, but it's only been within the last 5 to 7 years that they've gained momentum because of the technology advances with MRI. And our ability to see areas in the prostate that are highly suspicious for harboring aggressive prostate cancers. So these are two panels of the same prostate during the same prostate MRI study. I'm outlining with my mouse the prostate here, and this area here encircled by red, this wedge, dark wedge, is an area that looks suspicious and is confirmed suspicious after the patient gets a dose of contrast that helps highlight this area that correlates with this wedge in this particular area on the bottom or the peripheral zone of the prostate. So today, in 2020, when we're screening for prostate cancer, as mentioned, we do a PSA annually, we examine the prostate annually, and if either one of those two tests are abnormal, that patient is referred to a urologist, and based on his or her analysis and examination of the patient, a 4K test might be done, a select MDX might be done, and also an MRI of the prostate. If the MRI sees a specific lesion or area of the prostate that is highly suspicious for prostate cancer, then a targeted fusion biopsy is done. Now, this is important because this is also a new technology that allows us to digitally fuse the ultrasound images that are done in real time on the patient with the MRI findings that has already been done. And we can merge those two and specifically biopsy that area in the prostate that is most highly suspicious. Now, we also biopsy the rest of the prostate because MRIs are not perfect, and they will miss about 15% of significant or potentially lethal prostate cancers. This is an example, or a cartoon basically, of how a biopsy is done. The urologist is represented here, looking into the ultrasound screen. In today's world, he will also have the MRI on a different screen. The two will be merged, and he will perform a biopsy of the target, but also of the rest of the prostate. This represents why the target could potentially be missed on the old-fashioned biopsy, because we didn't know exactly where to go. These little black lines are representing the biopsies, whereas the lesion is represented in different areas in different men, different lesions in the prostate. But now we can target those areas specifically to make sure we're giving the best possible biopsy that will yield the best possible results. This is an example of a schematic of different areas in different prostates that have been biopsied, showing how we can map where the biopsies are positive, and that can help determine what kinds of treatments are best for the patient. Also, once the biopsy is done, then it's reviewed by the pathologist, of course, and the pathologist determines whether or not there's cancer there, and then he determines the aggressiveness or the invasiveness of the cancer, referred to as the Gleason's grading and Gleason's scoring. And this represents the ability or the aggressiveness of the cancer's likelihood to spread and to grow within the prostate, to grow locally and extend outside the prostate, or to move to different organs such as lymph nodes or bone. Now, when a gentleman has prostate cancer, he's often faced with this laundry list of potential options for treatment. There are radiation options, there are surgery options, there's active surveillance, hormone therapy, cryosurgery, freezing part of the prostate, HIFU, using high-intensity focused ultrasound to effectively burn or ablate part of the prostate. These are called focal therapy. Rarely, but sometimes, chemotherapy is used. And there are a laundry list also of experimental therapies, looking at new vaccines or immunotherapy or gene therapy. So in order to help the patient determine what kind of treatment is best for him, the urologist, the radiation oncologist, and oftentimes the medical oncologist will work as a team to determine what kind of treatment is best based on the overall health and life expectancy of the patient, the Gleason's grade and score, the PSA value, the MRI findings, the clinical stage or the local extent of the cancer, and other studies such as bone scans, CT scans, PET scans. So in conclusion, it's clear to me, and I think to most of the world and experts with prostate cancer, that screening for prostate cancer saves lives by allowing us to find the cancer when it's most treatable. Furthermore, using newer forms of testing, like I presented, 4K, select MDX, MRI, and MRI fusion for better biopsies, we're better able to determine who needs a biopsy. And from that, we're better able to determine who actually needs treatment. And furthermore, the treatment can be tailored to the individual for best results. Thank you for your attention, and I hope you now better understand prostate cancer and prostate cancer screening.
Thank you so much, Dr. Wilson. That was an excellent talk. Please, if you have any questions for Dr. Wilson, drop them in the chat box and hit send. We're now going to move on to Dr. Shemek Twardowski. He is our medical oncologist who joined us from City of Hope, and he's going to talk about imaging strategies for prostate cancer.
Good afternoon. My name is Dr. Shemek Twardowski, and I'm a medical oncologist at St. John's Providence Hospital in Santa Monica, California. I specialize in the treatment of genitourinary malignancies, including prostate cancer. And I wanted to share with you some insights related to developments in the imaging of prostate cancer. So imaging refers to a variety of scans and x-rays that we do to try to determine the location of prostate cancer. And that is important at the time of original diagnosis, when we are dealing with a new discovery of prostate cancer, and we're trying to determine the extent of the disease that really determines how we treat the patient with prostate cancer. So we historically have been using a variety of scan modalities, including CAT scan, bone scan, MRI, and those are reasonably effective in determining where the cancer is located. But there is a lot of uncertainty with some of these scans in terms of definitive extent of cancer. And that really has a critical implications, because if the cancer has spread outside of the prostate to distant locations like bones or lymph nodes, then the treatment would be quite different versus when it's still localized to the prostate itself. And the same is true in the other setting that we frequently have to use imaging, and that would be in the circumstance when the patient, for example, had primary, what we call primary therapy with a curative hope. So somebody who might have had surgery or radiation treatment, but now they have suspicion of cancer coming back based on the blood marker that we have in prostate cancer called PSA. So if the PSA is rising after prior therapy, that typically indicates that it's coming back. And it's also critical in that case to determine where is the location of that recurrence. Is it still in the vicinity of where the prostate used to be, or is it more distant? And we have also historically relied on relatively traditional types of scans, including CAT scan, MRI, and bone scan. And it's been shown that really they have significant limitations in our ability to detect, to localize where that recurrence of cancer is. Many of you are familiar with PET scan technology. That has also been around for quite a while, but unfortunately the contrast materials that were used were not very effective in discovery of prostate cancer. So traditional standard PET scans are very good in the management of lung cancer, for example, colon cancer, lymphoma, but not quite in the setting of prostate cancer. And that is beginning to change. This is one of the important developments in the field of imaging of prostate cancer, that we're now beginning to test and incorporate into the clinical practice new PET scan technologies that are really helping us to localize prostate cancer with much better sensitivity and accuracy. And I wanted to share with you the slide of image obtained through this new type of PET scan technology. So you can see the kind of silhouette of the patient from the side, and even those of you who are not quite savvy in human anatomy can probably recognize the appearance of the spine that's right here, and the liver is here, that bowel is here, obviously the face is here. So a lot of these findings here are completely normal and expected, and you definitely have to have experience in radiology training to visualize this tiny abnormality, this orange dot that is present kind of right in front of the tailbone of the patient. And this shouldn't be here. That doesn't normally belong here. And this is in fact the abnormality that is consistent with the site of prostate cancer recurrence. This patient has been previously treated with surgery and had evidence of rising PSA blood test, but we couldn't see the location of that recurrence on any other standard imaging test that we did. CAT scan was negative, bone scan was negative, MRI was negative. So this was very helpful because that allowed us to focus more precisely on this particular region with a focus new generation stereotactic radiation therapy to really address that abnormality with much better precision that we would have been able otherwise. So we are quite excited about this technology. We are currently conducting a clinical trial utilizing this novel generation PET scan in this kind of circumstance, like in this patient, but also in patients who are newly diagnosed with prostate cancer and are being considered for prostate surgery. So that allows for more precise, accurate staging, determination of extent of disease. So I hope you found this interesting and useful. We are very excited about this new development in the field of imaging of prostate cancer.
Thank you so much, Dr. Twardowski. That was a great presentation. We really appreciate your time. If you have any questions for him, feel free to drop them in the chat box and we'll try to get back to you. We're now going to move on to our final presentation with Dr. Mehran Movasagi, Director of Men's Health. He's going to talk to us about the very controversial testosterone replacement after prostate cancer. Thank you, Dr. Movasagi, for your time.
Good afternoon. My name is Mehran Movasagi, and I am Director for Men's Health here at Pacific Men's Health at St. John's Health Center, and also Assistant Professor of Urology at the John Wayne Cancer Institute. And I'm happy to be here today to talk to you about testosterone replacement and prostate cancer. So let's get started by looking at what testosterone does for your body and how your body uses it. Well, testosterone is the male sex hormone, and it's produced by the testes, and its production increases during puberty, and it is relatively maintained through the first few decades of a man's life. It helps regulate sex drive, sperm production, bone and muscle mass, the way men store body fat, red blood cell production, as well as mood and energy. So what happens if testosterone is low? Well, there's a reduction in sex drive, which can lead to erectile dysfunction. There's a reduction in energy, weight gain, potential feelings of depression, moodiness, reduction in body hair, and at times osteoporosis or thinning of the bones. We generally refer to this phenomenon as andropause, and reduction in testosterone begins as early as age 30, but it usually doesn't become symptomatic till around age 50 or 60, usually the same time that most men are diagnosed with prostate cancer. So how is prostate cancer related to testosterone? Well, up until 1941, we didn't realize that testosterone helps fuel prostate cells until in that year, Higgins and Hodges won the Nobel Prize for Medicine for reporting that a reduction in testosterone can help prostate cancer progress. So for decades, testosterone was thought to be contraindicated in prostate cancer because the thinking was that if taking testosterone away will help reduce prostate cancer proliferation, then giving testosterone is likely a risk factor that can lead to prostate cancer evolution. This, however, was never actually proven. And it wasn't until the 1990s that we started seeing that men that were on long-term anti-testosterone therapy, either through surgical castration or medical castration with medications that can lower testosterone levels, were dying prematurely, not only from cardiovascular disease, but from hip fractures, from osteoporosis, from anemia. So the paradigm started to shift to say, well, is this really true? That does testosterone replacement cause prostate cancer? So in some of the studies that I'm going to share with you in a minute, we saw that men that were actually treated or had low grade focal disease could safely undergo testosterone replacement therapy. And in fact, testosterone replacement doesn't lead to prostate cancer, and in some times can be protective for its recurrence. Furthermore, it can also serve as a stress test of sorts. So if a guy that has no signs or symptoms of prostate cancer and would otherwise go undetected for years, undergoes testosterone replacement and develops an elevation in their PSA, which is a blood test to help screen and detect prostate cancer, then that guy is likely going to be diagnosed much earlier and be treated much earlier than someone that had not gone on testosterone replacement. So testosterone replacement after prostate cancer treatment can be done, but it's usually done in the setting of a localized disease and also treated disease, and not recommended for high-grade cancer, and it does require close monitoring. So what is some of the data? So a study from Memorial Sloan Kettering, which was published back in 2015, followed 1,500 men for 15 years and looked at the two groups, men that had been on testosterone replacement after prostate cancer therapy and those that had not, and found essentially no statistically significant difference between the two groups. So men that had undergone testosterone replacement had similar recurrence rate as those that had not. In that same line of reasoning, in 2019, data was presented with over 28,000 men that had undergone radical prostatectomy or prostate removal, and another 45,000 men that had undergone radiation therapy. And in this group, about 1.5% were on testosterone replacement. And in comparison to the patients that were not on testosterone replacement, there was no increased risk of prostate cancer recurrence or death from prostate cancer in a 7-year follow-up. In that same year, more data was presented at the European Association for Urology, where it was shown that in a group of 834 men that underwent prostatectomy, those treated with testosterone replacement actually had a slower risk of recurrence to prostate cancer than those were not treated. So in the main group of 834, we had 154 patients that were treated with testosterone. Only 5% in that group had recurrence, whereas 15% in the no treatment group had recurrence. So the thinking now is not only is testosterone safe, it may even be protective against prostate cancer. So what's our take home? Testosterone replacement after prostate cancer treatment is safe, maybe even protective. It can not only improve quality of life, but potentially quantity of life in terms of cardiovascular health, bone health, mood, and depression. But it does require stringent monitoring and commitment from both physicians and the patient. Thank you guys for your time. Feel free to reach out either to our office or through the website. I'll be here for some questions.
Wow, Dr. Movasagi, that was a great talk. We really appreciate that. If you have any questions for Dr. Movasagi, please drop them into the chat box and hit send. Let's go through the questions. One of the first questions I got was, what do you think of the new liquid biopsy test? Well, that is a great question, but there are several types of liquid biopsies. There's the liquid biopsy where you can look for circulating tumor cells that are actually in the blood, or sometimes you can look for cell-free DNA that is in the blood or the urine. There's not a established liquid biopsy test yet for prostate cancer, but I think these tests are coming. We just have to get more specific about finding the actual cancer cells. The next question I got was, are you awake when undergoing the HIFU procedure? No, you are not. You are actually under anesthesia in the operating room, and it takes about an hour and a half to treat one lesion on the prostate, and about 3 hours if you're going to end up treating the entire prostate. Now, you do go home the same day, and you'll be up and around after the procedure, but you do have to have a catheter in your bladder for at least 5 to 7 days. And then after that, we take that out in the clinic. So it is a little bit of recovery, but it's very minimal downtime for the procedure. I had a couple of other questions here. It said, with longer life, is there still an upper limit to the age for testing? So the AUA has recommended continue testing if you think the patient is going to live 15 years or longer. The American Medical Association felt that after 76, you should stop testing for PSA. But I think as far as urologists, we still do continue the testing, especially if we feel like the patient has significant longevity. My next question I got was, Dr. Krisaloff, who is a local urologist in Santa Monica, put me on an anti-inflammatory diet. My PSA dropped by 4 points from 7 to 3. Unfortunately, he retired. Does that mean I don't have cancer? And if so, can I adjust my diet and enjoy a glass of wine? So yes, you can occasionally adjust your diet and enjoy a glass of wine, but that does not necessarily mean you don't have cancer, but it's much less likely if the PSA is going down. What I always tell patients is that the PSA, the velocity of the PSA or whether the PSA is going up and down is actually more important to me sometimes than what the number is. Because I have patients that have really big prostates that will have a PSA of 16 or even 20, and they've had that their whole life and don't have any cancer. And then I have patients that have a PSA of 2 and have cancer. So it really depends on if the PSA is moving up or down, and to help with that, a patient should be followed by their primary care or even better, their urologist. The next question is, what is the difference between bioavailable testosterone and free testosterone? Testosterone in your blood is actually bound by 2 different proteins. And there's a protein called the sex globulin binding protein. And if the testosterone binds to this protein, it is no longer free to act on the receptors and actually help your body. If the testosterone is bound to the albumin, then it still can come off the albumin and circulate in your bloodstream and help the different cells that it needs to. So bioavailable testosterone is the amount that's actually available to bind to different things and may still be bound to the albumin protein. And the free testosterone is actually what's floating around free, not bound to anything. I think that was all the questions that I had there. So Dr. T, one question we had for you is, what are the different types, again, of nuclear med testing for prostate cancer that's metastatic, that after the cancer returns, what are the types of tests that you do and why?
Yeah, Jennifer, great answers, by the way. Thank you. I've learned a lot from these presentations and your answers. So this test that we use, they reflect sometimes practicality and what we have access to. But looking, for example, for metastatic disease, traditionally we have always used a combination of bone scan, or more precisely technetium bone scan. So technetium is an isotope that tends to accumulate in the bone areas when there is a high activity, metabolic activity in the bone that may be related to cancer sitting there. And since prostate cancer tends to spread to the bone preferentially, that's the natural test that we do. But we know that the sensitivity or precision accuracy of the bone scan is limited. Part of the problem is that it overlaps sometimes with arthritis, which also can cause hot spots on bone skin. So, but anyway, still use it. CAT scan is also, of course, very well established technology that focuses more on the soft tissues. So looking at lymph nodes, liver, lungs, it can also provide a little bit of an insight into some of the bones. But also it is really relying on enlarged kind of organs that are invaded by cancer. So it's just based on the that, it's not totally accurate. MRI can also be used in kind of supplementary fashion. It's particularly good for bones. It has some limitations in terms of it's difficult to get a whole picture of the whole body using MRI because of motion artifacts, breathing. So it's not the best kind of global look at the human anatomy as the whole body. And then, as I mentioned in my presentation, the PET technology is very attractive because it kind of combines anatomical images, but also what we would call functional images with this special tracer that is being developed that has particular affinity to prostate cancer cells. It really can provide more accurate depiction of the body and prostate cancer involvement. But I would say that in terms of the imaging for metastatic disease, those are the modalities that we're using: bone scan, CAT scan, MRI, and then more and more PET scan is becoming a big player in that area.
Another question was, what can you tell us about the vaccine for prostate cancer?
Oh, that's an interesting question. So there is actually something that's already approved in prostate cancer that you could theoretically call vaccine, because it has a lot of the elements of the vaccine type of therapy, and that's something that you obviously are familiar with, Jennifer. It's a drug called Provenge, or Sipuleucel T. So it is actually FDA approved. It's been around for several years, and it does have that vaccine type of pattern of activity, because what you do is you take patients' own immune cells from the blood, and then they are incubated in the presence of prostate cancer proteins for a couple of days, and then reinfused back to the blood. So they kind of start acting as a vaccine. They get essentially immunized to prostate cancer proteins. So that's one example of vaccine-like therapy that's already approved for patients with metastatic prostate cancer. And we use it in selected patients. I think it particularly performs well in somebody who has relatively low volume of cancer. I think once it becomes very, very extensive, it seems to perhaps overwhelm a little bit of the immune system. But there are other vaccines in development for prostate cancer, but I have to admit that there have been quite a few failures, unfortunately, with vaccines specifically designed for prostate cancer. So that's a real challenge to develop vaccines that are active. Prostate cancer is a little bit elusive in that area.
Thank you very much. That was very helpful. We have now hit our 1 o'clock hour. So I'm going to end our webinar today. I hope it was helpful for you. And if you have any questions, call us at our urology department. It's 310-582-7137, or you can email us. So thank you very much. Have a good day.